Alrighty. So our next presenter is Ashley Madsen. She's a certified physician associate, trained at St. John's University, Stanford, Institute for Integrative Nutrition, and Institute for Functional Medicine. She practices in New York, California, and Florida, focuses on precision medicine, functional medicine, anti-aging medicine. She's also a lecturer for multiple groups, including AMMG and GAMAS now. Her lecture, Nutrigenomics, Integrating N-of-1 Data to Improve Patient Outcomes to Address the Future of Human Longevity in Nutrigenomics. So it's a really interesting talk. Please welcome Ashley Madsen.
Okay, I'm trying out the headset today because I'm Scandinavian, and as per Dr. Lee, we're very active. So I'm really excited to talk about nutrigenomics today because I think it's a really helpful tool to utilize in clinical practice, not only in recognizing disease, but also reversing it, and if anything, slowing it down. So we do a lot of genomic testing in my practice. It's a precision medicine practice that's based on individuality. And we know about bioindividuality, that every single person encounters things differently in life, and how it affects them is very different. And so I started off in the most reactive area of medicine. I did my training in surgery, and I worked 10 years in surgery, and I worked with some of the most amazing surgical teams in the world. We did replants, we were doing flaps, I was seeing a lot of burn patients, but my practice started to shift more from trauma to people coming in with arthropathies, inflammatory conditions. I was seeing peds, so I treated congenital all the way through. And so I worked with a lot of kids with arthrogryposis, cerebral palsy, and then I was starting to see kids with JRA. I was seeing kids that come in with eczema and all of these joint issues. And I said, there's gotta be something here, right? And as we know, and it's environmental, there's a lot of different contributing factors, but we can use genetics to really help not only adult patients, but peds. My lecture today is really gonna be focused on nutrigenomics for adults. And I'm going to go through 3 different case studies where I've been able to utilize it in a way to, number, recognize disease, but also to slow it down and reverse it. We can talk probably an entire day about genomics and how it can be utilized in practice, but today we're going to focus on nutrigenomics, which is very exciting. All right, let's get into it. So first we want to talk about what the difference is between nutrigenetics and nutrigenomics, right? So this is a lot of times used interchangeably by clinicians, and it can be utilized in that way, but we know that genetics is really the blueprint, right? It's the insight that we're given about how we're going to interact with our environment, with our nutrition, with environmental toxins, etc. And so we want to think about it in that factor there, absorption, transport, metabolism. And then when we talk about nutrigenomics, it's really the action, right? So it's more or less what happens when that gene interacts with that nutrient, or what happens if it doesn't turn on or turns off. So nutrigenetics and nutrigenomics is really sort of more important than ever because we know that dietary recommendations are based on population, right? And they're really based on inadequacy or excess, right? Just like if everyone uses their lab ranges in practice, if it's Quest or LabCorp or whomever, I'm allowed to say things because it's non-CME, so don't sue me. But we know that those ranges are not optimal. Those are based on populations, and they've changed. One of my mentors is a really well-known pediatric neuroendocrinologist, and he said, Ashley, in the 1970s, when I graduated medical school, before you were born, the upper limit of AST was 25. Now, I don't know about you, but the upper limit of AST and Quest is certainly not 25. And that's not because all of a sudden we decided that it's okay if that liver enzymes are elevated. It's because it's based on metabolic dysfunction that's happening in the world. So those are not optimals. Those are guidelines, right? So we're here because we want optimal. We want the best for our patients, and we want to execute that flawlessly. So we use nutrigenomics in many ways. So we know that every subgroup is different. What we call this N-of-1. So if you're in research or understand or scientific journals, we call it N-of-1, meaning each person is an individual. And what you want to understand is that everyone has a unique health challenges. I treat twins, and they completely interact differently. One will have breast cancer, another one won't. And they have a pretty identical genetic code, right? But we know that how their choices are, what their nutrition is, what they're exposed to, ultimately is going to turn up something or turn down something. So we have unique responses to medications. We use pharmacogenetics in our practice. I use it a lot with psych. So I work with a lot of psychiatrists, and we figure out, hey, how are they metabolizing these medications? And also supplements. Supplements are not benign. Even though they're not FDA regulated, let me tell you, I've had some people come in who've come from holistic practitioners, and I love functional medicine, don't get me wrong, but they've come in and their anxiety is through the roof because they have COMT genes, right? COMT, you can't break down adrenaline. You put someone on quercetin, right? We talk about senolytics, we talk about health. It makes them crazy. It makes them anxious. That's not good. You can also give someone too much methylated B vitamins. I've had some people come in like, I can't sleep, I'm super anxious, because they gave them so much methyl B12. So please understand that supplements are beautiful and they're amazing, and they can be used instead of pharmaceuticals, but they can also be harmful. And so we need to understand that everything that somebody is going to ingest really is only as good as what they do in terms of digestion, absorption, transport, and utilization. So nutrigenomics, how can we utilize it? So we heard Elliot's talk, which was great, and we can use it to help drive certain dietary recommendations. So some people can do really well with keto. Some people can really do well with paleo. Mediterranean is sort of that like safe place. I find Mediterranean to be one of the better diets if you're going to recommend. Really good in those healthy fats, so those proteins, and fiber, right? So we know that fiber is very important for people. So I've had people do really well with keto, especially some of my kids who have ASD, and sometimes even with ADHD. It's been absolutely amazing with epilepsy. Mark Hyman talks about it a lot in his practice, how to utilize it, but it's not the best for someone. I've had it tank someone's lipid profile and really affect them in a negative way, and also put on weight for some of those people. We know that some people have gluten antibodies, right? We have some disposition for celiac disease, but also leaky gut in terms of cell turnover and how our body utilizes it. Dairy, of course, we talk about that. Mitochondrial support, we're gonna have an amazing lecture from Dr. Gonzalez later, but mitochondria diets are real. So if anyone actually studied with IFM, we actually have certain diets that we give people depending on if they have neurodegenerative disease or they have a predisposition for them that helps to support mitochondrial function. And then, of course, fasting mimicking diets. You know, some people, I throw CGMs on every single patient who walks into my office because it's amazing you can find how sensitive people are to foods. And just because they're eating non-processed foods doesn't mean that they're not having this glucose and insulin roller coaster. And they're like, I don't understand. I'm eating the most perfect diet. Why am I still gaining weight? Or why can't I feel better? Why can't I drop my A1C? And it's because everyone responds to nutrients differently. I've had people eat cookies and their glucose is like this. And I've had someone eat a banana or an apple and they're flying high, 250, and then they get this reactive hypoglycemia. So we know that there's no perfect diet. It's $1 billion industry. But everyone is unique. And so we really can't sit up here and say, you should eat this and don't eat this, right? We can make some general recommendations, but when you have genomics, you can give them real individualized, perfect recommendations. So we know that also in terms of risk factors, right? Cardiovascular disease, Alzheimer's, dementia, obesity, I know Elliot covered that pretty well today. How we metabolize caffeine and alcohol. This is an interesting one, right? So I've had some people, they have a SNP that if they drink too much caffeine, it can actually cause them to have an early onset MI. And, that's a problem. We don't like that, right? So we also, how we metabolize certain nutrients, chemicals, right? So we think about benzenes. Benzenes have been in the news, right? Everyone knows about glyphosate in here. If you don't, I hope you learn about it. Glyphosate, which is Roundup, has been linked to malignancy. It has been linked to increasing ASD in kids. It is a problem. And if you study glyphosate levels that were actually approved in the 80s to what the glyphosate levels that are approved now, it's sickening. It's not, again, because we all of a sudden found this to be less harmful. It's just that there's a lot of bureaucratic political stuff behind it, right? So if there's some really good studies out, you can read about how they actually tested glyphosate levels in urine, and it's pretty enlightening. So then also, how about different compounds? Now, I typically use nutrigenomics in my practice to I make bespoke custom blends for my patients because I don't usually give them multivitamins, and I don't give them to a lot of things because they compete. You have to understand that a lot of these compounds will compete with each other. B12 and folate, a lot of people don't talk about that. If you give too much folate without giving them the B12 first, you can actually compete and the folate wins. And so you have to understand that everything is unique and different. And there's a lot of education that's out there that's free. So if you're using any of these advanced labs, they do great clinician trainings, and certainly you can find some more information too on how to do responsible recommendations. And then also dosing and the root of the medication or supplement, right? So I have a really hard time getting people's magnesium RBC levels up. And a lot of times it's because they have these certain magnesium SNPs that make it impossible for them to absorb through their gut. And so these are people that are going to need transdermal application or IV, right? We have to go to see how it works there. Or they need a different form of magnesium. Magnesium glycinate's the hot one right now. Oh, you should take magnesium glycinate. Let me tell you, magnesium glycinate doesn't always move the numbers. So sometimes you do a trimag where you may combine like a citrate with a glycinate. I love L-threonate because it crosses the blood-brain barrier. It's amazing for people who have ADHD, who have cognitive decline. So there's a lot that can be said in terms of how to work with your patients. All right, my first patient here, Maui Jim. If you guys are sunglass fans, then you get the reference. He lives in Maui. His name's not Jim. And he came to me. He's actually one of my favorite patients. And I treat a lot of West Coast peeps because I cover our West Coast office in California. But he flew in to see us, and he is like a self-quantifier, biohacker type. So he kind of had been to all these amazing clinicians. And he's like, listen, I just really would love to hear what each place tells me, like, and kind of understand and try things out. So I said, okay, let's do it. And he never had his genomics looked at, but he was starting to have brain fog. He was starting to notice that his attention span was declining, and he was concerned because his mom has dementia, and she's still alive, bless her heart here. But he's like, I'm really concerned. So I said, okay, let's take a peek under the hood, right? Let's take a look here. He also has ADHD, so I just wanted to point that out there. He doesn't take meds for it. He's just, he's really against it. He really wanted to try and improve his focus in a more natural way, and he's been able to do that over time. He doesn't respond to stimulants well. So I said, okay, let's take a look here. So I'm going to put up these cognitive memory SNPs, not because it's nutrigenomics, but because this is a patient that I commonly see in my practice. When we have ApoE4 SNPs, everyone freaks out. It actually is a low penetrance gene, meaning that just because you have it doesn't mean you're going to get Alzheimer's dementia. It's what we call a polygenomic situation, right? When it's monogenomic, it means that when you have that gene, your likelihood, or high penetrance, your likelihood of having that disease is pretty much there. BRCA1, BRCA2, some things that are affected by hemophilia, right? And there's only a few of those that are out there. And I did just some training with a phenomenal geneticist out of Children's Dayton Hospital in Ohio. And, he was really saying, like, you gotta look at the whole picture. So you can't just run genomics. You got to look at someone's personal history. You got to look at that family history. You've got to look at their personal lifestyle, their sleep, their exercise, their nutrition, their stress, and see what is all really look at the whole picture and then make the determination of what SNPs I really need to look at. And when I say SNPs, I don't know, I sometimes will talk to people and they're like, well, what's a SNP? Well, SNP is a mutation, it's a variant, it's a polymorphism. They're all interchangeable names of some sort of error that happened in the genome. Humans are 99.9% identical in genetics. It's that 0.1% that is the defining area of what changes hair color, eye color, disease states, detox levels, your toxin burden. So really, that's really where that sort of information is most important. And when you think about the alphabet, right? So English, 26 letters, Spanish, 27. You think about it as DNA has 4 letters. It's A, C, T, G, right? And they come together to form words or sentences, and they then do different processes in our body. So that's how I like to think about it. But sometimes those words get mixed up, and those sentences come out a little funky. And that's really what a SNP or a mutation is. It doesn't mean that you're going to die. It doesn't mean that you're going to have a horrible disease. But it means that it makes you different than somebody else. And those differences really are what we want to focus on. So for this gentleman here, I'm going to use my little pointer, he has ApoE34, right? But he also has TOM40. Elliot talked about this. TOM40 you need to understand because that affects mitochondrial membrane health. And it's about 70% inherited with ApoE4 SNPs. Now you also have some of these other big ones right here. And BCHE I consider one of the biggest switch-ons for Alzheimer's dementia. So in combination, this is what I call a polygenomic view. So not only does he have ApoE4, but he's got all of these other ones that are going to turn it up. So this is like walking down a train track with Alzheimer's dementia train barreling down on you. So we need to work on this, right? This is important. So what are we going to do? Now I'm not going to focus on those today. I'm going to focus on genomics. So first I run his micronutrient panel, and this is intracellular micronutrients. So we can test blood levels. Blood levels don't tell the whole story. You only really care about in certain ways if it's making it to the receptor, if that receptor is evaluating it and it's actually going into the cell. So the first 2 he has is glutamine and B12. So glutamine is really an interesting one because it is a non-essential amino acid, meaning we synthesize it. I rarely see glutamine deficiencies in people unless they're traumatic, they're having burn issues, they're actually having some serious traumatic injury. B12, yes, we know, that's a little bit more common, but still interesting because he has an omnivore diet. So going on to his glutamine SNP, he has this one here called ADGRL3, and this one is an increased risk for ADHD and Alzheimer's. And the reason is glutamine is the most abundant in the brain and also in our muscles. I know we focus on leucine because we want, muscle hypertrophy, but glutamine's pretty important. Now, there are a bunch of studies that show that if you give kids glutamine, it can help to reverse their ADHD. But we don't do that because the thought is, well, we make it, so we don't need it, which is kind of silly, right? Because if you think maybe you have a deficiency in it, and we should test for it. But that's not how conventional medicine is built. We don't test for things, we just give medications for things. And so this is an important understanding to know. So by giving him glutamine, we can actually help him with his ADHD and his Alzheimer's predisposition. And so it's also very important for ammonia toxicity, so us getting rid of that ammonia. And it's also really important for intestinal lining. So I don't know how many people treat gut issues in here, but glutamine is phenomenal for leaky gut. So I use it a lot. Any patient who has autoimmune disease, the understanding is they should be worked up for gut issues, right? So leaky gut is a big contributor to some of these autoimmune, especially if you have like Hashimoto's and your antibodies are through the roof. Look at the gut, look at the gut. And so this is really important. So we started him with L-glutamine. We gave him a pretty conservative dose, 5 grams twice a day, and I tracked him for 2 weeks just to see how he was feeling. Some people you can push it up, you can actually go up to 40 a day, but typically, 5 grams twice a day is a good starting dose. You want to try and take it away from other protein or amino acids because you don't want them to compete with each other. And you don't want to mix it in hot liquids. So I told him you can have it with your water, hold it under your tongue, whatever works here. But he started feeling amazingly well, and he's continued with it since. Now, B12 SNPs. So I know a lot of people think about MTHFR for folate and some of those things. And some of these genes get a lot of sexy press. And then we forget about all the other stuff. That's actually pretty important. So he has these 2 genes here called TCN1 and TCN2. And these are proteins that are really important in the transport of B12. So B12 comes into the gut, and then TCN1 takes it from the gut and transports it to the brain. Now, he's got a problem with that. Why do we even care about that? Well, B12 is super important for cognitive memory and health, right? So it's very important, not only for red blood cells, but it's really important for the brain. Then you have TCN2. He's homozygous for this. So TCN2 is responsible for taking the B12 and circulating it through the tissues of the brain. So he has a serious problem with transporting B12. So even if his levels looked pretty good, and I sometimes have this argument with PCPs all the time, they're like, oh, he has a B12 level of 800. Well, if you have genetics like this, then you actually need a B12 level in your blood about 1500 or greater. So you need to work that. You need to get that level up, and you need to test it and track it. I did a lot of work with him. I got him on testosterone. I optimized a lot of different factors. The one thing that made the most remarkable difference in this man's focus and cognition and life was B12. He called me up, and he's in Hawaii. I was in New York at the time, so it was late. And he was like, Ashley, I don't think I've felt this like clear-minded in years, maybe 20 plus years. He goes, I woke up, I was focused. He goes, I felt good energy, I killed it at the gym, and I'm doing phenomenally well. He goes, I tried it out, and I actually did an extra dropper of it. And I was like, okay. I was like, slow your roll, like, let's first see how you're doing with the one dropper. Now, we gave him sublingual, we gave him a methyl B12, and he did phenomenally well with it. He also has this other gene SNP here that relates to B12 availability in the mitochondria, and also decreases B12. So this was fun. I mean, honestly, I was just like, out of everything we did, it was the B12. I was like, all right, I'll take credit for it. That's fine with me. But he had been to a plethora of clinics throughout the world, and this was never picked up. So it was just shocking to me. Now, looking at his homocysteine SNPs here, we all know about MTHFR in here. Now, he's homozygous for MTHFR 1298. And that speaks to more neurotransmitters, right? So less about the blood clots and the stroke and the hearing loss, but more towards neurotransmitter. And why is that important? Well, he's ADHD. So we want to care about some of those neurotransmitters right there, right? It's also important still in converting that homocysteine back to methionine, right? And we care about that. Why? Because homocysteine is an inflammatory amino acid, and in high levels, it irritates the lining of the blood vessels. We don't like that, right? So he also has these other SNPs on the pathway, MTRR, MTHFD1, and FOLR1, and those speak to more folate transfer. Now, folate is super important for memory and cognition as well, and that circulation to the brain tissues is very necessary. So he's got some problems with transport of folate into the brain due because he doesn't have very sharp receptors. Now, when you have a SNP that affects a receptor, you have to make sure the serum levels are high. And the reason is those receptors and those cells are like hanging out, and you're like, hey, get me into the cell, and it's not responding. So that's a really important thing to know, is that if the SNP is in a receptor, you have to go up on serum levels. You have to check the intracellular levels, and you have to make sure that you're giving them the right compound in the right route. So that was very helpful for him. So we gave him the methyl B12 sublingual dropper. He did end up between 5,000 and 7,500 a day under the tongue for at least a minute. And then we gave him a vitamin B blend that had some methylfolate in it, B6, because B6 is very important for brain health, cognition, and serotonin production, riboflavin, thiamine, and B5, because B5, as we know, I'm not going to make you draw out the Krebs cycle, but B5 is super important for all of those processes in the body. Now, my next patient, Adventurous Sam, and the reason I call him Adventurous Sam is that he is a mountaineer and a very unique guy. And he came in because he was like, I'm doing really well. I'm physically active. I'm a pretty happy guy, but I'd really like to get my cholesterol down. And so, I went to a cardiologist, and he told me, like, listen, if you're not going to go on statins or PCSK9 inhibitors or, do all that stuff, go vegan. All right. So I'm like, okay, I'm not going to fight about it. I said, okay, so let's see how that's going for you. And he goes, yeah, he's like, pull out all the saturated fats from my diet. It's like, uh-huh. Okay, and then how is that veganism going? I said, do you track your macros? Do you take your supplements? What are you doing there? Now, this is not meant to be a shame on veganism versus carnivore diet, but you have to understand that there are certain nutrients that are found predominantly in animal-based products. And it's totally fine. I treat a lot of vegan patients. I actually have a lot of East Indian patients. And that's great. I think it's totally fine. But you have to make sure your patients are healthy and they're supported in a way of those nutrients that they might be lacking. Now, when I think about veganism and cholesterol, my thought is, okay, well, let's see what all your other biomarkers are, because we know that cholesterol is not just from diet. And we can actually check someone's production markers, we can check their absorption markers, and we can look at their genetics to see, is this person really getting their cholesterol issues from the diet? And we also know cholesterol is not the evil person in the room there. We can look at a CTA, let's look at his calcium score, let's run a Clearly test to understand what the soft plaque burden is, and then let's make some decisions there. So he doesn't drink alcohol, he, pretty healthy guy otherwise, but just the cholesterol he really wanted to improve on. So when I work with a patient, we have a very strict protocol. Everyone in my office that comes in, they get something called a hepatic elastography. It's a liver ultrasound that looks at how much fat is inside the liver, and it gives us also a stiffness score that's related to cirrhosis, right? So any scarring of the liver. And I found this to be interesting because I was listening to a podcast the other day, and the doctor on the podcast made a very clear statement where he said, vegans don't get hepatic steatosis. I beg to differ. And I said, never say never in medicine. Never say never in medicine. And so he had stage 2 hepatic steatosis. And that's really interesting. So I said, well, let's look at the most common causes, right? So we've got alcohol, infection, obesity. I worked him up for everything. We run over like 150 biomarkers on our patients. And so I was like, okay, let's look at his trigs and let's look at his nutrient deficiencies. That's what I'm leaning towards. We did a body composition. So he doesn't have the profile of someone that would have a fatty liver from a body comp profile. So if you're gonna look here, so you look at his skeletal muscle mass, I drew this out here, pretty darn good. For someone who's starting my program, this is more impressive than not here. So he's got a pretty good amount of skeletal muscle mass, and I'd like to drop his body fat mass down a little bit, but look at even his percent body fat over here is not too bad. And his VFA, which is visceral fat area, is under 100, which is considered optimal. So again, not really a profile of someone who would have hepatic steatosis from body comp issues. So now I looked at some of his biomarkers. I just highlighted a few that we were going to look at, again, when we're considering things. And, fasting insulin of 2.4, amazing. A1C is not bad. I usually like it closer to 5, but fasting insulin of 2.4 is absolutely amazing. I like it to be under 2 sometimes. And then hormones, he's, hypogonadism, he's secondary. I didn't put his LH and FSH here, but he had secondary hypogonadism. His T was low, his estradiol was low, his DHA is low. And why do I care about that? Well, my thought is choline. Choline is really important for taking fat out of the liver. And where does choline mostly come from? Animals, right? So it's usually big in eggs, so animal products, eggs, chicken, beef, things like that. So when I think about a vegan who has hepatic steatosis, my initial thought is choline in their diet. And choline is estrogen mediated. So who are the people who are even at higher risk? Postmenopausal women and men, right? Because they have lower estrogen levels. And his is 16. DHA level is also low there. And then, of course, his lipids, trigs were not impressive, 108, one under 70, but again, not a profile of someone that I would expect to have stage 2 hepatic steatosis. His lipids otherwise were terrible. He had an elevated LPA, he had LDL small particles were high, so we ended up doing the CTA with calcium. And his liver enzymes were, not great, but better, better than, again, not terrible. I also did his hepatitis panel, you test him for EBV and some other things. Everything checked out fine. And then uric acid was also great at 5.5. Under 6 is where I want to keep it. And uric acid, we should know, contributes to non-alcoholic fatty liver disease and diabetes. It's not just gout. Dr. Perlmutter wrote a really great book called Drop Acid that speaks all about this. So I highly recommend it if you're interested in that. And so let's look at his choline SNPs. He's got some 3 bad boys right here. He's got low choline synthesis, and this obviously will increase his risk for fatty liver disease. He also has a allele that increases problems if you have a choline diet, low choline diet, that also puts you at higher risk. And then he also has the decreased estrogen-mediated SNP. So you'll see this one right here. So he's got all three of the ones. So we're working against something. So although his cardiologist was trying to do the right thing, it wasn't the best thing for him. So what do? We put him on a choline supplement, a combination of two types of choline. We did citicoline, which is really important for brain, and we did phosphatidylcholine. And why did I put him on both? Well, because citicoline, when someone's going to have choline issues, we're not just thinking about the liver, we're thinking about their brain and their cognition too. So I do a combination of the two. Now, something to understand is that high choline supplementation should not be given to everyone because it causes something called TMAO formation. And TMAO puts you at higher risk for throwing clots. So when choline comes from your food, the latest studies that came out is that you have less likelihood of throwing clots from TMAO because you have less conversion if it's coming from natural sources. But when we're giving them actual higher doses of a supplement that doesn't come from Mother Nature, and there's a reason why we're supposed to get things from our food, that it can increase TMAO levels. You can test them, and I monitor them in my patients that I do put on choline. So it is important to consider that. How you can avoid this is divided dosing. So if you split up their dose and they're compliant with that, I would highly recommend that. So he did twice a day dosing. I gave him citicoline 250 at a time, phosphatidylcholine 250 at a time, and divided dosing. So he did 500 and 500 in the day. And then I also improved his testosterone levels, which made him aromatase, right, convert to some estradiol. We bumped up his estrogen levels. I gave him a DHEA supplement, and all of a sudden things were moving in the right direction. So let's see how his results were. So he went from stage 2 to stage 0 in 6 months. And so pretty darn impressive in my opinion. So my last case here today is Dr. Anna, and Dr. Anna is actually out of London, and I have a lot of international patients that I work with. And Dr. Anna is an anesthesiologist. She's really suffered with chronic migraines, and she was recently diagnosed with MS. And so she was coming to the States really to take a little bit more control of her medical health. And she was also concerned because her mom has macular degeneration and breast cancer, and she's got a lot of depression in the family. Right, so immediately I'm thinking mitochondrial dysfunction, right? We have to think about those mitochondria when we think about neurodegenerative disease. And migraines, I'm thinking a whole bunch of different nutrients. If anyone knows about Mayo Clinic's protocols, for migraines, we put people on zinc, magnesium, riboflavin, B12, and CoQ10, right? So those are the important ones when we think about migraines too. So let's look at Dr. Anna's biomarkers and micronutrients. So these are just a few that I pulled out. Certainly we did a lot more than this. And Dr. Anna, of course, you can see her levels are pretty much all low. Her homocysteine was borderline at 10. We want to drop that down. But she had the lowest folate and vitamin D level I have ever seen in my patients. And I was like, whoa, what's going on here? This is really unique. Yes, she lives in London, but this is unique. Vitamin D level of 7 is pretty terrible. Now I do treat, again, a lot of East Asian patients, and they tend to have very, very low vitamin D in the single units. Again, cultural differences make a difference because of genetics, right? But this is unique. And we know that B12, folate, and vitamin D are super important in MS, right? So there's a lot of literature because B12 protects the myelin. So neurologists who are very, who treat a lot of MS, they know they always test B12 levels and vitamin D, and there's a whole protocol for MS. Dr. Terry Walls, if everyone's familiar with her, she is a specialist in MS. Lots of literature that she comes out. She's doing a study right now, but these nutrients are very important. Her micronutrient deficiencies, abnormal CoQ10, B12, and B2, which is riboflavin. Shocking. This whole profile screams migraines and mitochondrial dysfunction. So we want to fix all of this. So let's look at her mitochondrial SNPs. There are two that I want to pull out. Here is CoQ2 and then the NQ01. So why are these really important? Well, they are involved in neurodegenerative disease, shocking, and they're a high correlation to low CoQ10 levels in the body. So again, I wasn't going to have you guys draw out any of the fun ETC and the Krebs cycle and everything else, but you know, CoQ10 is a really defining nutrient antioxidant in the body, and statins we know reduce it. So anytime someone is on a statin, they should be on CoQ10 therapy, and those levels should be monitored. Usually, you can do it through Boston Heart, Cleveland Heart, but that's really an important antioxidant to make sure your patients have on board. And so she's homozygous in these two SNPs, and this really is a problem because one of them is involved in the first step of CoQ10 synthesis, so she's like ready at the gate having a hard time. And then the other one is important in actually converting CoQ10 and vitamin E into their active forms. So we wanted to give her some love on that. And if anyone's familiar with Dr. Barry Tan, he makes a great supplement with Designs for Health that does a combination of the two together. And he has a lot of literature. It's a fantastic supplement that I use a lot with my patients. Macular degeneration. So when we think about age-related macular degeneration, which is central vision loss, it's very scary, right? And a lot of people go on these AREDS different supplements, right? That's a very common one that we hear about. Well, when you have this SNP here, the one that I focused on, the CFH1, if you take vitamin A, you have an increased risk of 80% of developing it. Now, how many of you think that vitamin A is great for your eyesight, right? We are taught that in school. Oh, vitamin A, beta carotene. Well, with these folks, you're actually going to damage their retina if you give them too much vitamin A. So AREDS 1 that came out was actually changed to AREDS 2, that supplement, because they pulled out the beta carotene from it because they found there was a correlation between beta carotene and lung cancer. And also, the conversion of beta carotene into active vitamin A is also controlled by a gene. So some people go on a lot of supplements, one being Nutrafol. I have a lot of ladies that take Nutrafol. Nutrafol has a very high dose of vitamin A in it. And so she was on it. So I took her off of it because we know that there's a lot that we can do for hair restoration that does not involve just that. And we were able to cut a lot of her risk by doing that. Vitamin A is also found in liver in high doses. So, you know, carnivore craze came out, people are eating liver, they're taking liver supplements. Be very mindful of vitamin A toxicity. It is a fat soluble, just like vitamin D. And so you can really cause a lot of harm if you're getting too much in your life for a variety of reasons. Also, vitamin D helps to drop this issue down too. So it can decrease your risk of getting age-related macular degeneration. So with her terrible vitamin D levels, we need to also make sure that's better. Then we look at detox, right? Detox is super important. I like to coin that nutrigenomics falls into lifestyle genomics, right? Because our toxin burden is going to change based on each of us. And she has a full gene deletion. So sometimes when we're making these words and sentences with these letters of our DNA, we do a really terrible job and the gene just deletes itself, meaning that you're not producing that enzyme whatsoever. This is a really problematic one, the GST1. And, what happened here? There we go. The GST1, because this one, yes, is really important for mercury detox, but this enzyme is needed to do a conversion process of taking a toxin, conjugating it into something that's non-toxic. It makes it water soluble, and then you sweat it out, you breathe it out, you get rid of it. When you don't have that, you are at great risk of problems that have to do with cancer and mitochondrial dysfunction, neurodegenerative disease. So what do? We want to upregulate those other detox genes. And you know what the best thing to do that is with? A very important plant compound called sulforaphane. And sulforaphane is one of my favorite supplements to give somebody. Number one, you can get it from cruciferous vegetables, but it's very difficult to actually absorb it in the gut. You have to break it down, you can't cook the cruciferous veggies, and it's a problem. But sulforaphane has a lot of data also as an anti-tumor. So anyone who has high risk for breast cancer, which she does, and prostate cancer, it can help change the tumor, actually decrease the tumor size in those folks, but it also is amazing at upregulating all your detox genomics. vitamin D SNPs. So we know there are something called VDRs, which are vitamin D receptors, and that this is actually vitamin D SNPs. So vitamin D receptors talks about when vitamin D hits that receptor, it triggers a different cascade effect, right? Kind of a domino effect. So when we have vitamin D SNPs, we're not talking about the receptor per se. She has a problem, and sometimes I get into like social media gets a little tiring, or these influencers come on, they're like, you don't need to take vitamin D, just go out and sunbathe. No, that's not how it works. Yes, UVB light hits the skin, it triggers a reaction which creates vitamin D3, but then it has to do a conversion process in the liver and the kidneys to actually get anywhere. And your exposure levels are probably going to be much higher and problematic than not. Even if she did that, she would never get the amount of vitamin D she needed. So this is a problem. So she actually has the enzyme DHCR7, or 7R, I should say, that actually makes her take the cholesterol from the skin and convert it more. So there's these different building blocks to cholesterol, and it's supposed to either convert into cholesterol proper or convert into D3. She has the problem where she converts more into cholesterol and she forgets the D3. So that's why her levels are so terrible. She lives in London too, so she's not getting that much sun anyway. But she also has the gene to increase the breakdown of vitamin D. So some people, they take vitamin D, they're given vitamin D for a month by their primary care doctor, and they're like, we fixed it. No. So yes, it is fat soluble, it stays in the body for a certain amount of time. That amount of time is going to differ for everyone. If you have a chronic problem, you need to have prolonged treatment. And so now we have to decide how we're going to treat her. So some people do really well with a large dose once a week. Some people need to have a smaller dose every single day. And that's going to be dependent on their genomics and how their body reacts. You need to measure levels. So yes, you can do prescription vitamin D2. I prefer to stay with D3. Orthomolecular makes a great 50,000 IU vitamin D3, so you don't have to do the prescription D2. They have a great product. And when you start someone on D3, you need to make sure they have what? K2. And that's because when you absorb the calcium, you need to drive it into the bones and away from the heart and away from the kidneys, right? So she did really good with that. She also had some B12 folate SNPs, so she had MTHFR. She was heterozygous for both 677 and 1298. And when you have a compound heterozygous pairing like this, you have to take the percentages from each of those. So she actually had a 52% reduction of methylfolate production because she had these two heterozygous SNPs. So we want to also make sure that we're giving her ample levels of folate and B12. And her folate was 4.2, so as you can imagine. And then, so this is just a little rundown of Dr. Anna's supplements. It's a non-CME lecture, so I was able to talk about brands, and I'm happy to talk more with you guys today if you have any questions about supplements. But this is a little bit of rundown. The sulforaphane one I want to highlight, it's called Avmacol. This one I love because it combines sulforaphane, myrosinase, which is a mushroom enzyme, and moringa, which is amazing for decreasing brain inflammation. So in summary, we want to talk about that everyone is unique. Dietary reference indexes are there basically to keep people safe, but they're based on keeping people okay, not optimal, right? That's our job, to make sure that people are optimal, and that's why we're all here today. And then we know that genetic abnormalities can result in altered nutrient status and influence the onset of disease. And then identifying these SNPs can allow us to, number one, optimize medications, supplements, and then dietary recommendations for our patients. These are references. And then this is my puppy. Today's his 11th birthday. So I thought we all need a little cheer. So today he turns 11. He loves hemp seeds. So he eats hemp seeds. My little vegan, see? Great source of omega-3 and protein, though. So thank you very much, and I don't know if we have time for questions, if anyone has any. Me?
Any questions? Do you have questions?
Yeah. Go ahead. That was a fantastic talk. Do you use that Intellex DNA SNP testing?
I use Intellics. I've used 3x4 as well. Dr. Yael Jaffe is the scientific officer for them, and they're great. But I love Intellics. I use Intellics predominantly. I'll also use Invitae. So I picked up Lynch syndrome in one of my patients using Invitae. They have a fantastic proactive panel. So if you're looking at certain pathogenic genes, those monogenomic genes, and then I'll use Boston Heart or Cleveland Heart for some of the cardiometabolic stuff too.
In regards to Intellics DNA, they have all different panels.
I do all of them.
Oh, you do the big mama.
Yeah, exactly.
So that's like $5,000 or something like that.
It's expensive, yeah.
Okay.
But it's worth it. So, I have a different demographic of patient, but I have to say, I have some colleagues who works in peds, and they've had some kids that come in, some babies with failure to thrive, and they've done Intellics on them, genomics on them, and they've figured it out. And they have, so again, you can use it on peds. The good thing about a lot of these genetics is that they're modifiable. So they're not as scary, I think, as sometimes people think they are. And so sometimes I have this conversation where patients are really nervous about knowing what their genetics are. And I'm like, listen, when we know about it, we can do something about it. And it gives us sort of a GPS. That's why I think family history is absolutely important when you're working with someone. You need to understand the GPS. You need to understand there's a pothole up ahead, there's an accident on exit 36, so we can avoid those things.
So another question, I see a lot of parents, their kids have ADD or ADHD, and sometimes they treat their teenage kids, and I do the genomics on it. So I'm just curious, in your practice, how fast do you see results once you get the results and they take the supplements?
It depends. So I don't treat as many ADHD kids. I treat more adults in my practice. I treat more metabolic syndrome and things like that for teens. But I know Sharon, she treats, and she works with a bunch of pediatricians and NPs who do peds, and I think they've had pretty good success. You know who, the company Nutrients, Emily Gutierrez, she's a nurse practitioner, she's fantastic. She came out with a supplement blend that was for pediatrics with ADHD, autism spectrum disorder, and she is fantastic. So I can't answer as much, but I think she's had pretty darn good results.
Well, okay, just look at your cases. How fast do you see results when you do the optimize their, let's say, deficiencies? Within a month?
Oh yeah, water solubles you'll see pretty quickly. That one patient, Maui Jim, he felt better within 3 days. He said the first day, but he didn't believe it. So he tried it out for 3 days in a row, and he goes, oh, now I'm believing it. The hepatic steatosis, that was a 6-month fiber scan. I did a fiber scan also at 6 weeks, and he went down to stage 1. So 6 months it took him for that.
Right.
And then vitamin D levels, again, vitamin D levels take a little time to rise. They're fat soluble. So I trend usually at 5 weeks. I retest them usually at 3 months. So it really depends on the person. But micronutrients, you can really you can see, especially the water solubles. Moving on. Great. All right. Thank you very much.